So our work that was presented essentially highlights the fact that during the course of our studies, we noted that only mice bearing active tumors were developing evidence of inflammatory colitis in response to anti-PD-1 immunotherapy. And this observation could potentially explain why other groups were not seeing evidence of inflammatory colitis in response to checkpoint inhibitor therapy in mice. So the finding is significant in that it suggests that a tumor-derived factor could be contributing to the development of this particular immune-related adverse event that is clinically significant as it impacts a large number of patients. So we also found that if mice had prior tumors that had been surgically removed, they also developed evidence of inflammatory colitis with anti-PD-1 therapy. And additional analysis of the colon tissues really indicate that there's a significant influx of neutrophils in those tissues, and that this neutrophil accumulation is playing an important role in driving Th17 differentiation and playing a role in the pathogenesis of inflammatory colitis, secondary to checkpoint inhibitor therapy. And so because neutrophils are very short-lived cell populations, the data really suggested that there was some form of imprinting going on in the innate immune system involving these neutrophils in the bone marrow. And that there was likely a factor derived from the tumor that was responsible for this process. And going back, we had previously found that a tumor-intrinsic NLRP3 inflammasome activation plays an important role in driving the recruitment and accumulation of PMNs and neutrophils. And so we conducted some additional studies to investigate whether or not this pathway could be contributing to this phenomenon, and found that, in fact, if you look at tumors that are genetically amplified for NLRP3, then they are associated with significant elevations in neutrophils in the colon tissue prior to treatment with anti-PD-1. And that these neutrophils exhibit very high levels of PD-1 expression and CXCR2 expression. So overall, the data suggest that in the presence of a tumor that is amplified for NLRP3, that the host is in increased risk for developing inflammatory colitis in response to checkpoint inhibitor therapy, and that the neutrophil populations in the bone marrow are undergoing epigenetic reprogramming by a factor that we have not proven yet, but we believe could very well be related to heat-shock protein 70, which is released from the tumor in response to NLRP3 activation. If we treat these mice with an NLRP3 inhibitor and compared with prednisone, they exhibit a significant reduction in evidence of inflammatory colitis and using various parameters, similar to what you see with the effects of prednisone. However, if you look at the tumor, those mice undergoing treatment with an NLRP3 inhibitor have a significant suppression in tumor progression relative to those mice treated with steroids. So the data overall indicates that treatment with an NLRP3 inhibitor is a strong, a very promising option for managing inflammatory colitis, in the fact that it can suppress the inflammation in the colon while also avoiding interference of the efficacy of anti-PD-1 therapy. The data also indicates, based on our clinical specimen studies in advanced melanoma patients, it also indicates that those patients that have elevated NLRP3 activity in their tumors, and which also correlates very strongly with baseline levels of heat-shock protein 70 in their plasma, are at significant risk of both developing a high-grade toxicity as well as progressing on anti-PD-1 immunotherapy. So that's the summation of the work that was presented last Saturday.